You are live now, ma'am.
Good evening, everyone. I, Dr. Anu Malik, extends a warm welcome to each and every one of you for joining us today for DOS Super Tuesday, an initiative by Delhi Ophthalmological Society, thanks to our President, Dr. Rohit Saxena, sir, and Dr. Praful Marana, sir, our Secretary. This is our third episode of Dry Eye Clinics, and this is on the topic Managing Digital Eye Strain and Dry Eye in the Digital Age. So as in our fast-paced digital world, most of us are spending hours in front of screens, and our digital lives are increasing eventually day by day. So today we'll delve into the causes, challenges, and management of digital eye strain. So before we begin, I'd like to introduce our esteemed speaker and expert panel for today. Our speaker for today is Dr. Priya Desai. She is a cornea refractive surgeon, medical director at Desai Group of Eye Hospitals, Baroda, Gujarat. She has achieved remarkable competence in the treatment of various diseases involving the cornea and anterior segment, as well as extensive training in the skills of various corneal and refractive surgeries. Besides having a vast number of presentations to her credit, she had conducted keratoplasties in Kenya in collaboration with Cornea Health and conducted various surgical and diagnostic camps in and around Baroda. She has numerous publications and presentations to her credit. Moreover, she is a designer, innovator of ERS light and imaging device used for retinal imaging, innovator of AIM 1.0, an anterior segment imaging system, an executive committee member of Baroda Ophthalmic Society. Today we have Dr. Radhika Tandon, ma'am, professor and head cornea cataract and refractive services at Dr. RP Center for Ophthalmic Sciences, AIMS, New Delhi, as chairperson. As discussants, we have Dr. Kiran Kumar, Dr. Gunjan Buddhiraja, a cornea specialist at New Delhi. Sohini Mandal, she is currently working at LV Prasad, Bhubaneswar. Dr. Surbhi Dutt, cornea specialist at New Delhi. Dr. Prabhakar Singh, working as faculty at AIMS, West Bengal. And our expert panelists include Dr. Jaya Gupta, cornea refractive surgeon, currently working in New Delhi, Dr. Rajesh Goel, faculty at SMS Jaipur, Dr. Parul Chawla Gupta, working as faculty in PGI Chandigarh. So I would like to thank all our chairperson and expert panels for joining us today. And I would like to welcome Dr. Priya Desai to the virtual stage. Over to you, Dr. Priya Desai.
Thank you, Dr. Ranu. That was really a vast CV. You would have probably skipped a lot of lines from that, but thank you very much for the warm welcome.
Thank you for joining.
And I'm very glad to see my friend Dr. Surbi here as well. And I wish all of you a beautiful evening. So I guess we'll start. How do I share my screen?
Now you can share.
Yeah, okay, I'll just see if I can. Is it seen, I guess?
Yes.
Okay, so, am I audible and can you see my screen? Are those two lines that I have used so much in those 2 years of COVID and I've completely forgotten to use them now. So, see, managing digital eye strain. So first and foremost, before we go ahead with this, we need to understand that dry eye is so vast that it's not possible for any of us to finish it up in like 30 minutes or 45 minutes. We just need to understand one very important factor, that what kind of patients are we dealing with? Because dry eye is no more just an absence of tears phenomena as it used to be initially. It now is so vast, where there is a huge role of inflammation, habituation, digital use. So here we're not going to talk about the entire dry eye. We're just going to talk about the dry eye that is induced because of the digital eye strain. So digital eye strain is an entity encompassing the visual and ocular symptoms due to prolonged use of digital electronic devices. I guess Why people have become more and more aware about dryness is that initially we used to have a lot of people coming to us with asthenopic symptoms, and we would just do a refractive error and give a simple lubricant and think that probably this is the much that we have in our forte. But after a lot of computers, and in COVID we've used a lot of our phones and everything, we've probably now realized that there's a complete separate entity, which is as important as any other ocular condition, which is the dry eye disease, and which is probably induced because of a lot of digital devices. They come to you with vague symptoms. They will come to you with dry eye, itching, foreign body sensation, watering, blurring, headache. You have a patient who is sitting in your OPD who is 6 by 6, N6, and that patient complains to you of blurring of vision. Initially, if this kind of patient would have come to me, I would have thought that this patient is malingering. But now these are the patients that I probably take much more seriously than I would be taking any other patient, because these are the ones that are your most non-happy patients that are going to be sitting out there in your OPD. So they also come with a lot of non-ocular symptoms. They have a stiff neck, they have generalized fatigue, they have headache, backache, and some of them say that I have a spinal problem and I've been referred to you just for an eye exam. And you realize that they're all induced because of their digital devices. And it had got prevalence, which was not as much in the pre-COVID area, but it has increased huge after the COVID era. And the development or exacerbation of these symptoms clearly depends on how much of system that they use. Okay, so what are the factors that we are thinking of here? First, the intensity. So you have somebody who's sitting on the system for 2 hours or 1 hour. You have somebody who's sitting for 8 hours, 10 hours. Then probably that person would come home, finish work, and then go on to seeing the phone, which is for another 3 or 4 hours. So the intensity of the activity on the digital device has got a lot of impact on the amount of dryness the patient would develop. Okay, then device characteristics, the digital display quality, the screen resolution, the screen size, the screen distance, and the underlying effects. Like, for example, what age of the patient are you dealing with? Do you have a female or a male? If you have a female, does she have any other associated hormonal issues which could probably precipitate the dryness induced by the digital device? Are they contact lens users? Are they having enough sleep? Because some of them also work in these call centers where they'll be working for the whole night and come home in the morning and again see their phones. So that's practically watching the digital device for the whole day. And also the kind of environment that they are put in. And they will be eventually, because of all this, a lot of accommodative symptoms, huge variations in their blinking rate, and all extraocular alterations. So this is like a lineup of all the symptoms. I'm not going to go through all of these, but you have to remember very clearly that, when your patient comes to you and is giving the basic history of sitting on the computer for a very long time, and you can see those sore eyes, you should know that what you're dealing with out here is probably dry eye. They come with all sorts of vague symptoms. And I think the weirdest symptom or complaint that a patient has come to me is that they'll come to me with a few MRIs in their hand saying that my neurophysician has done all the possible tests for me and they think they can't find the reason to my headache. And now they finally put it on to you because my general ophthalmologist has also told me that you don't have a refractive error. So either you're malingering or you need a psychiatric reference. And eventually, when you do a detailed workup, you realize that it is not the patient who's needing a psychiatric reference. It's us who need to do a proper evaluation of the dry eye, because the symptoms are so vague, you can just not make out that, okay, if this person is coming with itching in the eyes, it is allergy. If this person has a lot of discharge, you're probably dealing with an infection. But yes, your dry eye examination or your conclusion of whether this is a digital eye strain or this is an inflammatory dry eye completely depends on, one, your history, and two, your examination. We've got so many methods by which we can confirm dry eye. But for me, if you ask me, a basic, good, well taken history and a clear slit lamp examination with just 2 strips in your hand, a fluorescein and a Shermas, you'll probably get 90 to 99% of your answers just right there. So don't be in a rush to expose your patient to, doing an ocular surface analysis, doing a meibography, doing an OCT or film analysis. Just go ahead and try to find out why this patient is having a dry eye and what all things can you find in the eye just like that on your slit lamp. Okay, so sometimes, when you're talking to the patient itself, you can be able to evaluate how your patient is blinking. Does the blinking give you any kind of a message? So, when they're looking at their digital devices, they are definitely going to reduce they're blinking. Even we tend to do that. Probably while I'm conducting this meeting, my blinking rate is reduced way more than it is normally. And we all know that during our blink, that's the only time the tears have to come and replenish the entire ocular surface. Even if you reduce that from them, there is definitely going to be some effect on the ocular health after that. So reduced blinking associated with reduced replenishment of tear film and great evaporative loss. So it's like the water is not coming in and the one that's existing is moving out. It's a very simple way in which I will be explaining to all my patients in a complete basic way. And originally we used to do a lot of divisions on whether it is aqueous loss or mucin loss. Rather than that, we're first supposed to understand the symptomatology of the patient and do everything. Do your T-BIRD, do your knee-BIRD, try to evaluate, make the patient blink, see everything. But you have to understand that we need to know what the tear film looks like and what all layers can get affected. Now, increased OSDI and corneal staining, reduce Schirmer test scores, and reduce tear meniscus height and breakup time. These are our prime clues what we're dealing with out here. So, I have a lot of people telling me that, fill up that OSDI form and then do this and do that. And let's do some 10, 20 investigations and then probably let the doctor see the patient after that. But I always feel that look at the patient before you post the patient for any kind of investigations. Try to stain and stay there for some time. There are patients who will have a lot of delayed staining. Evert the lid and see whether you can find any kind of papillae. Look for the breakup time. Look for the height of the tear film. And when you're talking to the patient, analyze how well the patient is blinking. I think probably just by doing this, you will have a lot of clues. And see, I'm not going to go into the detail of the anatomy, but you need to understand that digital eye strain will affect all the layers of the tears. There will be meibomian gland deficiency. There will be chances that the patient will be rubbing the eye so vigorously while doing the work. And since the blinking rate is so less, there will be evaporative loss. There will be some amount of inflammation. So, the mucin layer is going to have a lot of inflammatory cells. So what we are looking at here is a single symptom, a single cause with multiple reasons. So what we need to understand is we don't need to go into the detail or why this would be happening or how this could be happening, because those answers, probably doing an ocular surface analysis, we will be able to get those answers. But what we need to primarily understand are the habituations of the patient. When I'm actually treating my patient for a digital eye strain, I always tell them that your treatment is not going to be me doing 5 tests for you and writing some 5 lubricants or an anti-inflammatory or a steroid or a cyclosporin drop for you. For me, your treatment is going to be habituation changes and medicines. If you don't follow all those habituation changes, there is just no point in giving the patients any kind of a medicine from that entire potpourri of medicines we have for dry eye. So just do a symptomatology form. All centers have their different kind of forms in which they'll be asking different kind of questions. We all develop our different questionnaires. It's okay, the kind of patients you get and the variety of patients you get, your digital eye strain patients and your RA patients, the arthritis patients should have a different kind of a questionnaire is what I feel. Make them fill up the questionnaire, do a basic slit lamp examination. When I realized that some of this patient who I'm dealing with here is a dry eye, I do spend a lot of time staining that patient and looking at that patient, because sometimes after doing that, I realize that there's no need of doing any other test. I kind of know my answer. Sometimes what you can do is you can evert the lid, ask the patient to look down, and you can, probably even see that gush of water coming between the blinks when you stain. So staining probably can give you a lot of answers. And do a Schirmer's test. Ocular surface analysis and an OCT tear film height is always an option. But I strongly believe that investigations are a supplement to your clinical judgment, not a substitute to them. So, how do you start treating these patients? Okay, so first, I think everything here in digital eye syndrome begins with counseling, because these patients have a lot of, these are people who are mostly seeing Google. So they have so much of extra Google gyan, as I tell them, that they think they probably know the treatment even before they come to you. So before they come to you, they'll wear these very expensive anti-glare, anti-something, whatever commercial glasses. Before they come to you, they've already fit some screen. Before they come to you, they already been putting some lubricant or some anti-allergic or some NSAID, before they come to you, they already know what the problem is. So why is this situation very difficult to tackle? Because now you're supposed to completely change on what they think and try to tell them something that they don't know. So ergonomics, I think, from the time we were in MBBS, it was a very basic thing that all of us were taught, that what position are you working in? What are your working positions? Even as surgeons, when we're looking through the microscope, you're dealing with a very difficult case. Sometimes when somebody takes a picture from far of you doing a surgery, I have a tendency of doing that I'll tell somebody to just take a picture, to probably show my daughter. And sometimes I do realize that, oh my God, this is how I was sitting through the entire surgery. Look at my back. It's like the shape of an arc. What is going to happen to me if I, keep on operating like this? So sometimes we need to understand that ergonomics plays a very important role in every single thing that they do. And this is what we need to sit, counsel, and tell them, because these are people who already think that they know quite a bit. So you have to tell them to limit their working hours. Now, here we've got two factors. For those who can do that, we'll definitely follow that. But those who have got compulsory working hours fixed, that they have to work for 8 hours because they're working in a particular IT firm or something, then we have to tell them to take frequent breaks. So what are the digital device practices? So this is what I call this is as computer hygiene on what every single thing that they should be told. And, I even have a leaflet printed, which they can take back home and read it at their own ease in case if they haven't understood what I tell them. Or probably I've told them so many points that they don't remember. So I tend to give them a leaflet in which it's written in very simple language on the do's and don'ts of computer use. So there should be good amount of lighting. The device should be positioned really well. The parameters of the resolution, text size, the contrast, the luminance, and the breaks. We all know the 2020 strategy. I'm not going to go into detail, but there are very few people who actually understand the 2020 strategy. And, we're all humans. We've all got different stress levels of working, and you can't really expect somebody to follow that bang on 20, but you have to make sure that you at least tell them that they should be somewhere around that. So the two very simple things that I tell my IT friends are that put a post-it over your desktop, write blink with a red marker, and try to put an alarm of reminder in your system of 20 minutes, so that whenever it's 20 minutes, your mobile will probably put a ping or probably remind you that, okay, it's 20 minutes, time you took off. And it is recommended to sit upright at a desk or a table where screens are approximately of a certain distance from the eyes. The height of the screen should be positioned lower than the height of the eyes, so it can be a 15 to 20 degree below the eye level viewing. And frequent blinking, as I told you earlier. And see, illumination is something that we cannot have fixed, like how I will be looking at something, how my environment is during the day, during the night. But what you should realize that it should be of a comfort situation. You should not be straining yourself or using a lower illumination to work. And probably it is preferable to use a black and white contrast. And the brightness should be adjusted that the light coming from the monitor matches the light at the surrounding workplace. So anti-glare screens and anti-glare glasses and all these are pretty much debatable because it completely depends on the basic condition of the eye. But I do have a lot of people who tell me that, yes, they are very useful to those who are using it. And I think font size is probably the most important thing that we need to tell them. And what I usually do is I have a little desktop on my consulting table, and I will just show it to them on the desktop that these are the font size that they should be using, and these are the font size that, they should probably avoid using. And there is something that is known as a screen time tracking, which is there in all the devices, which will be telling them how much of screen has been used. And you should ask them to track themselves every day, like how you ask a diabetic to keep a watch on the sugars. And it will probably encourage them. They will realize, okay, this was my screen time. I do that a lot with my son, and that has helped me, reduce his screen time quite a bit. And very importantly, refractive error. You have to make sure that when your patient comes, you don't only cling to the fact that, okay, this is a digitalized and confirm, let me just do this and that. Before doing anything else, do confirm what you're dealing with. Are you dealing with an emmetropia? Or do you have a patient who's like a 0.5 or a 0.75? If they do have some amount of glasses, make sure that that refractive error is corrected. And healthier lifestyles, we all know that that plays a long-term role, at least not a short-term role. And in case if you talk about children, that's completely a different topic, but the time of screen usage by children should always be monitored, and they should be encouraged to stay outside the house more than the screens. And if you go to treatment, so basically I have not written anything for treatment because it's a complete potpourri and it's such an individual clinician's choice on how you would be treating a dry eye. Should I be using this lubricant or that? And this is usually a very major point of concern or discussion of any cornea surgeon or any general ophthalmologist. And how I have simplified my use of these medicines are that the moment I realize, okay, this patient has got confirmed dry eye, and I need to find out the detail of dry eye, I'll probably do an ocular surface analysis. If I realize my patient has a meibomian gland dysfunction, I will give the patient hot fomentation. I will give the patient oral antibiotics. I will probably put the patient on a simple lubricant like a CMC or an HPMC, and I would teach them how to maintain their lid hygiene. If I realize that this is evaporative loss, then doing all those efforts are negligible. If I realize that there is a lipid loss, okay, so then I would probably use the lipid replenishing ointments that are there available in the market. But it is completely an individual's choice. But I guess if you go step by step, always start your treatment with a basic lubricant. And cyclosporin is by and large generally my choice. But always keep on evaluating your patients, and don't just jump onto using low potent steroids or oral medications, or give them a collection of some 3 lubricants, one for 1 hourly and a sodium hyaluronate. I think doing a potpourri of a lot of lubricants generally doesn't help. So give them a simple lubrication, and just remember, giving a dose which is 2 times in a day, 3 times in a day doesn't help, because the tear drops don't stay in the eye for so long. All the lubricant eye drops we're dealing with here, 6 to 8 times in a day at least they have to put. It's okay if you're giving a cyclosporin, you can give it twice in a day. If you're giving a chloroquine eye drops, you can give it twice in a day. But also together with that, they have to be told and counseled that just putting the lubricants is not going to help. They will have to do a lot of habituation changes at their workplace or at home if they're working from home. The other thing is that I always advise these kind of patients to put the drops like first thing in the morning and at night, which is going to be their first and last dose. And what that happens is that if the patient wakes up, puts the drop, takes a 15-minute rest, and then starts the day, the effectivity of the drops supposedly increases, is what I've been told by my patients. But you have to understand that putting the lubricant just twice in a day probably will not help. And certain things that you should always be telling them with use of lubricants or use of ointments or everything, that there are certain habituations that they will have to change at their workplace, is only when the medications that you're giving to them will work. Now, if you ask me for follow-ups, how frequently are you supposed to follow these patients up? Then I feel that at least initial stages where you want to see whether your patient is improving with the treatment that you're giving them, first 15 days and then every month. And don't promise them that their dry eye is going to be completely cured. Those false promises eventually end up being punishments for us, because they will have very high expectations. They will come to you asking, when am I going to be completely okay? When am I going to completely stop putting? Tell them that this is going to be a process, and it is going to be a 50-50 process of their cooperation with our medication. So always explain to them that dry eye is not something that you can just sort it out in 1 month or 3 months. And I think that probably will encourage the patient to use drops for a longer time, reduce your defaulters, and probably you will get a chance to evaluate whether a particular medication that you're giving is working on them or not working. And in case you want to change them, you can. So quickly going through the message, the high computer use is a high visually demanding task, and vision problems are definitely going to be there because of that. And the usual symptoms are going to be headache, eye strain, irritation, and the symptoms usually occur because of poor ergonomics. That's like the only answer to this. And you will have to differentiate a digital eye strain from a normal dry eye or an ill ocular health surface, which is probably because of other systemic reasons. Do never forget to do that, because the treatment will completely vary in both these cases. if you have a patient who's having both the issues, for example, a patient is arthritic, taking medicines for a very long time, and having exorbitant use of the computer. So now you're dealing with somebody who has got uh, a lot of inflammatory dry eye as well as digital eye strain. So your methodology of treating this patient is going to be completely different. You also will have to treat the systemic disorder along with treating the dry eye. And application of the eye drops constitutes basic therapeutic approach, and it can be implemented in areas of computer utility. It is most feasible, economic, and easily accessible. Okay, I guess that's it.
Thank you, Dr. Priya, for your insightful presentation on a very prevalent yet very significant condition.
I think I was not even breathing between my slides.
We really appreciate the time and effort you put in for sharing your insights.
So, in case if I'm allowed to ask one questions to all the panelists, that how is your approach different than mine? Is what all of us would ideally be good to discuss. Is that what kind of patients do you get in that part of the country, and how do you normally deal with it?
Hi. So we normally deal it in a similar manner as yours. So we get a lot of computer vision syndrome patients and children. So they have a lot of asthenopic symptoms and dry eyes, but we mostly treat them as evaporative dry eyes or MGDs. And we give them lubricants, and we also prescribe the lipid layer substitute drops, and we advise them environmental modifications, not to use too much of air conditioners, use some protective glasses which can decrease evaporation, use visors while driving on the scooters or the motorcycles. So all these, they decrease the evaporation and they decrease the discomfort associated with the dry eye. Then we also give some antibiotics, like in later stages, we can give some antibiotics, especially in cases associated with MGDs. We give 1 gram azithromycin orally once every week for 3 weeks. So that also makes a difference, along with some omega-3 fatty acids. So that also decreases the inflammatory markers, and it helps in the dry eye. And in the patients with systemic disorders, dry eye, yes, with systemic disorders, we also have tried autologous serum drops. So in a concentration of 50%, they worked very well. So giving them 4 to 6 times a day, 50% autologous serum eye drops, they are a good way to combat the dryness. So patients are very happy symptomatically, even though the parameters don't improve too much, but they are happy symptomatically.
Do these patients, does any one of you have that experience of patients keeping on asking you any diet tips to improve dry eye?
Yes, definitely. I myself advise them to get a vitamin D, serum vitamin D level, because that has been shown in studies to be associated with dry eye. And most of them, as we all know, that most of them are deficient. So they are given a proper course, that is 60,000 international units once every day for every week for 8 weeks, and then 1 monthly subsequently. So I do advise them vitamin D on a regular basis.
Okay. Thank you.
Hi Priya, how are you?
I'm fine. How are you? Good to see you smiling as always.
Yeah, same here. Great presentation, and I must say, dry eye, the way you have told, it's absolutely correct. It doesn't define a protocol. You have to base it on the patient individually, because each patient's ambient environment, the whole sitting posture, the ergonomics, and also what we deal with in that part of the country is very, very important. But yeah, digital eye strain, I feel, it's become very pandemic type now. It's all across in all age groups, actually. Even the schoolgoers and everyone, they're hooked up on screens because of their unfortunate school time. Also, they're given submissions online. It's very difficult actually to give a blanket therapy. But yes, of course, the outdoor activities, you have rightly said that that really helps. And especially for people who are sitting in the office, I feel, I always tell them, you know what, you can, similar to how you've said now, to put a timer and all that, I tell them, just get up, go to get something, like, go for a glass of a cup of coffee, water, whatever. At least you'll get away from your screens, because what they have done, what I have seen, they stop their screen, but they go to their phone. So it doesn't help. You have to actually leave all screen and move away. So
Move
your,
away.
your eyes become a little more comforting, and they're not seeing a gadget. That's the main thing. But yeah, I mean, everything has been covered by you. So I don't really think that the 15-day part, I don't follow it. I keep it as a month.
Mhm.
I don't give any topical antibiotics if it's a simple kind of, digital eye strain, which we have. It's not combined with any other kind of complex entity in it, like an infection or, any sort of autoimmune conditions. If it's a simple digital eye strain, I tell them what has to be done. Leaflet really helps, but I don't know how much the OSDI scores and all that. What I do is I finish the whole checkup. I finish giving them the treatment. I put it in the file. I say, go home, sit on it, put your marks, and come back with it in a month. And then
Makes
I'll,
sense.
because it takes chair time, and they just agree because they're not able to recollect it, and it's a chronic problem. It's not a acute problem that they will remember all the things. When they're sitting and they know what they're facing, they might be able to pick it better. Like, is it 2, is it 3? It can be any questionnaire. It could be a speed, it could be OSD, it could be anything. And as far as the oral tablets, Osmega, we all know the studies have proven it really doesn't help. So I don't really go into Osmegas. But yes, Doxy, if it's combined with MGD, it does help, definitely. Doxy, or the other one, the Azithro, any one of the two.
I think one more thing that I have started doing, which has really helped,
Yeah.
which all of you can try to put into your practice, since you live in a city which is way more bigger than mine, at least in your areas, at least, what I've done is I talk to all the people of the optical shops around me. And I try to tell them, if you have people who are coming to you for glasses for computer and you're evaluating them for refractive error, you realize they're 6 by 6, and you end up giving them those, 10,000, 20,000, or even more expensive glasses for use of computer. Why don't you ask them to do an ophthalmic reference once before you go ahead and give these glasses? So we've started actually educating the, optical
Yeah.
shop people and the opticians, and that has actually made a lot of difference, at least in my area, that
Yeah,
now people have
I
started
agree.
coming to me, and they're not, unnecessary wasting. In the optical shop, the person doesn't feel that, okay, I'm losing, a customer, because eventually that patient will eventually go back to the optical shop for a pair of plain anti-glare glasses or for protection from, air while they're driving on their bikes or something. So I think that's one thing that also probably can help all of us in our practice.
Absolutely, absolutely. And of course, one more thing which I tell the patients overall is not to splash water into their eyes.
Oh, very
Just
important
keep doing
instruction.
that. They just keep doing that, and I'm like, every time we have to, emphasize it. And the more we say it, they realize that they're not supposed to do it. But then again, we have patients who still keep doing it. Yeah.
Dr. Priya, we would like to know, are there any evidence-based interventions that you have done in your practice that have proven to be effective in reducing the symptoms in occupational settings?
Well, if you ask me honestly, none actually, because what I've realized that there have been so many variations that I couldn't have got to a certain conclusion that, okay, this is an X group of patients and I have tried this particular strategy for them and it has worked, because it just doesn't seem to work for all of them in the similar way. I would give them a perfect ergonomic setting. I would give them a similar kind of treatment protocol. But what I realize, how their body responds to these protocols is so different that I can't get to a conclusion like how a lot of studies do, that, okay, this particular group of patient responds exactly like that. Trust me, in a private practice like mine, just doesn't seem to work for me.
And one more point which I really wanted to in this platform to discuss would be the type A personality patients. I think they just don't get over the dryness. There is a neuro pathway which really affects, even if they come to us and they say, like, doctor, I've done everything which you've taught, and yet I'm not really being helped. So I think
But
that
those are the
one
patients who come with those psychiatric reference letters to
yes,
me. Trust me.
yes, yes,
Because they
yes.
are going to make you type A eventually.
Yeah,
Treating them, you
absolutely.
realize you've become a type A eventually.
So that is called neuropathic pain. So they have
Yes,
neuropathic type of symptoms. So it is called
absolutely.
pain without stain. So
And
it's
that's
not
Yes.
very difficult
pain,
to treat. That
but
arm of
very difficult.
patient,
Yes.
because you have to be so sensitive that you can't label them that you have a lot of stress. But of
Yes.
course, you have to subtly, very, very carefully tell them that, there is an arm of, this pathway, which is neuronal, which you need to cut off. Take small, gradual steps. Go for a walk, relax, listen to some soothing music. We have to indirectly tell them. We really can't tell them that, look, you're taking too much of stress and let's hold on to your computer. You can't do that because their work is on that. You can't do that.
And
I've had a word with some of my colleagues who are practicing in the US or in the UK. They spend so much time for their dry eye patients. That amount of time, I guess we will be finishing our entire OPD during that time. The amount of time that they spend for just that one dry eye patient. And I have a colleague in London City Eye Hospital, and I always tell her that how come you're spending 2.5 hours for one patient? What do you tell them for 2.5 hours? And I think probably what you're saying is what they would be doing out there is probably trying to tell them to, settle down, de-stress a little bit. And that's when probably these medicines are going to be helpful to them, or probably they'll start realizing that they're working on them.
And how does this digital dry eye patients differ from other forms of dry eye? And does your treatment differ specifically in these patients?
They differ because they know what you're saying is not true. Because they know what they believe, what they've read from Google is way more true than what you're trying to tell them. No, on the lighter note, that was. So a digital eye strain patient, if you ask me, is a combo patient. It is not just a simple dry eye patient who I will be evaluating for a systemic disorder, and I would probably be looking for a meibomian gland dysfunction or trying to see a very systematic etiology, because in this case, I already know the etiology. I know what the causative factor is, and I know precisely what I'm supposed to do about the causative factor. Just correct those 1, 2, and 3 points, and the DES patient will definitely be sorted. And you have to tell them it's multifactorial. It's ergonomics and treatment. If we work on both sides, that's when these patients are going to get sorted.
So there is individual variability and an individual susceptibility, both.
I guess you've said it in a much better way than I could have.
So patients also ask what are the potential risks of using these lubricant eye drops so frequently?
And my answer to them always to this is, it is way more better than you splashing water at home into your eyes. And it is way more better than you just walking into some so-called Ayurvedic store and buying the drops in which you have no idea of what the content is and putting it in your eye. And I would definitely talk to them about habituation, that, don't habituate yourself to putting drops all the time. Do try to make yourself become okay by just a little bit of habitual changes, instead of, making sure that, okay, you end up putting drops all the time. But at the same time, I'll also be counseling them that, putting these drops will not harm their eyes. They need to understand that before they apply these drops in their eyes.
And we get one more question from the patients, like how do smartphone and tablets use differ? They usually ask us how do they differ in their impact on the eye health, on the ocular surface.
So for that, I need to understand the difference between a time bomb and an atom bomb, because if they both blast, they're both going to kill anyways.
Yeah.
The difference
These are
is
the common questions we usually encounter in our practice, like patients come.
I always tell them, I have a lot of people telling me that my son is watching a lot of tablet. So can I just do that? That can I just take the tablet away and make them watch television? So my first question is, for how long is your child going to watch television? They don't have an answer to that, because that could be 4 hours or 6 hours. So eventually the damage is going to be the same. So a lot of people said that, looking at the phone has got more damage, but what are you comparing it with? If you're comparing it with going and playing outside, then fair enough. But if you're comparing it with watching another digital device with probably bigger fonts for longer hours, then the calculation is eventually the same. So my recommendation is probably take more breaks, reduce the hours, and the hours that you have left should be utilized in staying outside that environment rather than the same environment.
And we also need to tell them that using these smartphones is way more dangerous than TVs, because there is a convergence excess that takes place. So there are many new cases of new onset myopia that have taken place and have been seen post COVID also, and even increase in the amount of myopia that has been noticed with the near vision devices. So probably the mobiles are a big no-no, but if they want to watch television, so that can be like 1 to 1.5 hours, not more than that. In fact, they say, as you also mentioned in your presentation, the screen time should be less than 4 hours.
Less than
So
4 hours.
yes, so that is the ideal recommendation. But we need to tell the children and their parents that they don't need to watch more than 1 to 1.5 hours.
Yes,
And
absolutely. I completely agree.
smartphones are a big no-no.
Yeah, completely agree.
So actually,
It's
these
such,
are
it's such an endless topic. I'm telling you, we can generate so many questions and discussions that whenever dry eye as a topic is ever put onto a discussion, it always seems that the talk after that is definitely going to get delayed, because it is such an endless, in fact, even therapeutics, dry eye, what to treat, what to give, it's a completely separate discussion on its own, but it's absolutely subjective. I don't think there's ever going to be a fixed protocol in treating a dry eye patient. I don't think so.
And some things we should advise to our patients while using drops is that we should tell them to keep the drops in the refrigerator, not in the freezer, but the refrigerator, because it increases the viscosity of the drops. If they are left at room temperature, the viscosity will decrease. And as you rightly said that if a patient really needs the lubricant drops, 4 times a day is really not enough, because the ocular residence time, as seen in previous studies, is very less. So for a hyaluronic acid, it is around 11 minutes. For HPMC or a PVA, it is around 40 to 49 seconds. So if you're giving that drop, the residence time is just less than a minute. So you can't prescribe just 4 times a day. It needs to be more, like you said, 6 to 8 times at least. And one more thing, that the HP guar, it works at a alkaline pH. So it is a gel, like we use it in Sustain Ultra, HP guar. So that is in a gel form when it is in an alkaline state, like in a pH of around 7.5. But if we combine Sustain with aminoglycosides, they work at a pH which is around 7, less than 7. So the combination does not work. So we have to mix and match the drops and the lubricants and the antibiotics in such a way that they don't negate each other. So that is another point.
That's a very important point.
Yeah.
That's a very valid point. Yes.
Yeah.
So we have our discussants also, Dr. Prabhakar, Dr. Gunjan.
You're on mute.
Is he muted?
You're on mute.
Or am I deaf? He's muted.
Dr. Kiran Kumar.
Hi, Dr. Anu. Thanks for the invitation. And it was really like wonderful discussion. You guys are talking. And we have been like seeing like wherever CME, any conferences, dry eye is a major topic. And still we have been discussing. And even if we see 40, 50 patients, out of which at least 20 patients will be dry eye every day. And the same family, 2 to 3 people will be there with the dry eye associated with the digital eye syndrome. And how difficult it is to prescribe the same medications to different patients of the same family. There are sometimes if you get like same family, you have siblings. And some people do, they give sodium iodinate for a patient and they'll give PEG to a patient. And they'll do a comparative study among themselves and they'll come back to us. He's feeling better than mine. So we just wanted to have a questionnaire regarding this, and we did a study. Like it's basically depending on the symptoms, like what they give. Not all dry eye associated with the digital age will have common symptoms. Like some guys will have like dryness or grittiness, which persists the entire day. Or some people will tell like my eyes are red always, like whenever I'm working on system. And some people might even tell like whenever I get up in the morning, I have like dry scales all around the like eyelashes. So here we need to see like actual etiology. Accordingly, we might have to give whether it should be given a CMC or sodium iodinate. If suppose a patient is working out full night, that's like very common in the post-COVID and work from home concepts. Because most of the US companies, they like employees from India, they have to work in the night time. So when they get up in the morning, like they usual complaint is like there are dry scales all around the eye. So if for such patient, if you give CMC or something, it's not going to help at all. So what we feel like we have to give something like mineral oil preparation so that will take care of their eyes for the entire night. So when they get up in the morning, it will be totally smooth. At the same time, when you have like grittiness persisting for the entire day, we can give like sodium iodinate, okay, which stays on the ocular surface maybe for 10-15 minutes. So we can't even tell them apply every hourly, every 2 hourly, because it's humanly impossible for us to be compliant with medications. And most of the doctors only nowadays, like they are like seeing most of the things on screen only the full day when you see. So basically, it's a multidisciplinary approach by an ophthalmology. I can tell like that. We need to see like each and every aspect pertaining to dry eye and contributing factors and any other etiological factors which are associated for making them more susceptible for the dry eye associated with this digital eye. Because the final thing we have to accept is like dry eye is here to stay as well as the digital strain. So somehow we need to manage this smartly so that patients will be happy. So most of the patients, they're all Google patients, they'll search everything. They'll know better than us in most of the time. Like you tell a brand, they tell I've already been used, I've been to 7 other doctors and you're the eighth one. So we have like limited the portfolio of medications. So maybe 4 to 5 dry tear supplements, or at most we might add an extra low potent steroid or a cyclosporin, as ma'am was telling. So basically, it's a case to case based treatment we might have to follow in managing this dry eye. I think Prabhakar also will agree with this.
You're
Prabhakar, I
actually
think you have to
muted.
unmute.
You're
Yeah.
muted still. Yeah.
I think
No.
there is some problem with Prabhakar's system. So what I would like to ask the panel, like, what is your experience of many people prescribing blue protective glasses to avoid digital eye strain nowadays? And there are so many reels on social media everywhere, even in Facebook or Insta, like GMB. Whenever we see, like, there's a big marketing strategy happening for selling by this blue protective by the optician companies or by eye hospitals. What is your experience, Dr. Priya?
So if you ask me, what I will clearly counsel is I don't contradict the. Can you hear me?
Yeah, yeah, please.
Yeah, okay. So I don't contradict the use of these glasses, but I will always very clearly tell them that if your eyes are not healthy, no glasses are going to work for you. So make sure you're treating the dry eye well and then giving them these glasses as a supplement and making sure that you counsel them that this is just going to be an extra effort we are going to put to make them feel better, but that is definitely not the therapeutic treatment for their dry eye. That's all I don't contradict use of anything like screens or glasses. They probably all have their roles, but you have to make sure that when you're prescribing this, you're dealing with a healthy ocular surface, not with an existing severe dry eye or a digital eye strain patient. Otherwise, nothing is going to work. Nothing.
So blue light actually it disturbs the circadian rhythm. So it inhibits the melatonin. Melatonin is a sleep hormone. So if you don't sleep well, so there are studies in literature which say that poor sleep quality, it increases the dry eye. So we have to tell our patients that you have to have a proper night's sleep, like 7 to 8 hours, because if you don't have that, then it will increase the tear osmolarity and further increase the vicious cycle of dry eye. So sleep is a very important component and it is a doable component.
Am I audible?
Hi, Prabhakar.
Yes,
Yeah.
Yes, now you're
Hi.
finally audible.
Yeah, hi Kiran. That was
Hi,
a
hi.
wonderful presentation, Dr. Priya. And yeah, very rightly said that it is more important to evaluate dry eye related lifestyles and the demographic factors that is associated with digital eye strain. And we can say that dry eye is just one component of digital eye strain, and we cannot separate it from the entire digital eye strain. Like, say you are treating only the dry eye, the patient will never be happy. So any patient with computer vision syndrome that I am treating, I guess they are never happy with the treatment that I'm giving to them, just because of the reason that probably apart from dry eye, something else need to be treated. So they must be saying that, okay, symptomatically they are better. However, they are not happy. Again, because there are so many components apart from dry eye in the digital eye strain. So I think that is something we need to take care of. And there are so many platforms now available, like virtual distant viewing technology, like you're working on a laptop or you're working on some tablets. But there are several distant viewing technologies available these days, which people can use and reduce their eye strain. And that way, when you couple it with dry eye treatment, they're going to get benefited.
I can totally agree on to that one. Makes sense.
So like in the panel, like I would like to ask, like which is the like most common medication which you advise on a day-to-day practice for a corporate who works for at least 10 to 12 hours a day with classic like symptoms of grittiness persisting entire day. Choice, maybe we can take the molecule name, not the brand name here, so that we know like how is our like treatment, is it falling in one place or all of us are prescribing different things for different patients? How is it?
So in my practice so far, I have seen like people are very happy. I mean, not very happy, I would say again, but they are little symptomatically better with PEG, like polyethylene glycol, and so that sort of drops. And apart from that, hypermelos also I have seen they are like little better than with that.
So in my practice, I usually prescribe sodium hyaluronate, and the patients are quite happy with that because the ocular residence time of sodium hyaluronate is much more as compared to the other drops. So I feel they have to put the drops lesser number of times, but they have more comfort.
I would probably have a two-way thing if I'm completely in favor of sodium hyaluronate, but I need to understand how competent is my patient going to be? How often are they going to be ready to put the drops? If I have a patient who's really compliant, then I think a PG is okay. But, I know a patient is non-compliant and they're going to put the drops just 3 to 4 times in a day. I would get away with a sodium hyaluronate rather than giving them something that needs to be put for, 8 to 10 times or 6 to 8 times in a day. So again, it's probably again a very variable answer, I guess. But the choices can go between these two for sure.
Hi, good evening, everyone. So, any idea how moisture chamber glasses may help such patients? Because a lot of practitioners somewhere are giving moisture chamber glasses, especially in Western countries. A lot of people are prescribing moisture chamber. So, any experiences with moisture chamber glasses in your practice?
So in my practice, I have seen patients coming up with this kind of glasses, but the indication was something else. I mean, the patient was not having issues with this symptoms of computer vision syndrome. Rather, the patient had dry eye vision because of cicatricial conjunctivitis that the patient had in the past. So I had seen them using those glasses, but I haven't come across any patient of computer vision syndrome with these glasses.
Me neither. I don't think I have also come across any patient like that.
Yeah. In fact, that becomes foggy at times, and it's very difficult for the patient to use it.
So I think we have had a very
it's very difficult to do day-to-day activities with moisture chamber glasses.
Yeah,
And it's very uncommon in the clinical practice. It's almost absolute now. The most importantly, what we advise is to go for the frequent medication, whether it is a sodium hyaluronate combination with PEG. It works excellent. And if you want for night coverage, you should always add a mineral oil preparation, so that will give like smoothness which persists for the entire night. And early morning, you won't have any difficulty in opening eye, because most of the patients, they do like complain of early morning very grittiness as soon as they get up in the morning. And the CMC, HPMC, that depends on patient's affordability also. And one more thing, what I suggest, we should also see the company and where they get these raw materials for manufacturing this sodium hyaluronate. When you actually uh, see there are like the price ranges are entirely different from company to company. But definitely there are some companies which has like very good raw materials, but which works very excellent for the same molecule. Suppose a patient is unhappy with sodium myelinate with some particular brand. Yeah, if you give some reliable brand sodium myelinate, it will work. So not all preparations are acceptable by the patient. So it's always better to see that also while treating the dry eye patients.
Exactly. And we can also give some osmoprotectants like L-carnitine or trehalose. So it has been seen that if trehalose is combined with sodium hyaluronate, it gives a better outcome. So
I agree to that.
Hellos
that
is always like it was a new kit and now it's become old kit, but still it is here to stay because it has a lot of anti-inflammatory action also that will definitely help you, especially in post-refractive surgery dry eyes, like especially in PRK patients. Trehalose has a magical role in the preventing this subclinical inflammation which occurs on the ocular surface. And definitely, it's very difficult to explain dry eye symptoms as a doctor. It's only the patient who experience this can explain it in a better way. But they do respond for the sodium myelinate and PEG combination in most of the cases.
So we think we have had very effective takeaways and discussion in this session. I would like to thank Dr. Priya for sharing your expertise and taking time to join us today. And we really hope for clarity in this screen-driven world. And I would like to thank all our expert panel and discussants for sharing your experiences. And I would really like to thank all our attendees for joining us for DOS Super Tuesday.
Thank you very much. It was
Thank
very
you.
interactive indeed. We had some very healthy discussions. Thank you very much for the invitation. Thank you so much.
thank you, Dr. Anu.
Thank you. Thank you.
Everyone have a lovely evening. Thank you.
Thank you. Thanks a lot.
Thank you, Dr. Anu.